So we're recording, so nobody, no swearing, no, you know.
Yeah, I can't promise that.
All right, good,
Are you
good.
sending yours into BSAC HQ then for them to put up on their website?
I don't think they'd be interested in this, Gareth. They want some proper instructors doing that, not me. Right. So yesterday we did DT5, didn't we? Good to get DT6 out of the way straight away. And what we dealt, well, what did we deal with in DT5? Let's see if everyone was paying attention and remembers. So we talked about oxygen administration equipment, and we talked about the components of oxygen administration equipment. So anyone got any ideas? Who's going to give me a starter on that one?
Is it a J cylinder?
Not
D cylinder.
That's the cylinder, a D cylinder.
Yeah.
Bonus points for size.
2.5 litres.
275.
Yeah, exactly. Around about 2.5, 2.7 litres. Another component?
Regulator, the demand valve, sorry.
Well, yep, there's the regulator. And how many outlets would we normally have on that as a minimum?
Two.
Anyone name them?
Constant one.
We've got the constant flow that's generally on that quick release, yeah?
Yeah.
And we've got the demand valve. Yeah.
Is that for you?
And will that regulator fit one of our scuba cylinders?
No, it's a 2-pin.
No, it's got that 2-pin indexed connection there. Our O2 sets have got those adapters that we can put them on a scuba cylinder if we need to. And with that demand valve, what sort of mask have we got? A normal mouthpiece or?
No, full face mask.
A face mask, yeah. An oronasal one. I'm not going to say oronasal because I can't get my mouth around it. So in future, when I say face mask, I mean oronasal. Okay. We've also got a storage case, haven't we? And the storage case, we normally have them in the brown tube, but they've got to have one thing on them. There's one specific thing that we listed.
A pressure relief valve.
A relief valve.
Yeah.
Right, magic. So before we go into this, I know that we've got people at different levels. So we'll do a quick review on DCI and what we all understand DCI to be. Okay, anyone know the abbreviation then?
Decompression.
Decompression illness.
Decompression illness. Okay. Now, I'll give you my view on this. Gareth and Bez, please add or subtract or correct me if I'm wrong. Okay, so when we go diving, the ambient pressure increases the deeper we go. If we think of the balloon diagram, so on the surface we're at 1 bar, at 10 meters we're at 2 bar. So we've increased our ambient pressure we've doubled our ambient pressure is what I'm meaning to say. And our scuba regulator delivers us gas at the ambient pressure. So when we're at 10 meters, we'll breathe. The gas that comes out of the mouthpiece of our regulator is 2 bar. If we go to 20 meters, it's 3 bar. Yeah. The deeper we go, the increase in pressure, the greater the increase in pressure. That makes sense? So it follows that the deeper we go, the higher the pressure of the gas that we're breathing. Yeah. And if we talk about air, again, Ruby, don't hate me for this, but air is made up of 21% oxygen and 79% nitrogen. That's not true, but that's what we make it. We're rounding up, aren't we? Yeah. So while we're diving, we're breathing an increased pressure of oxygen and an increased pressure of nitrogen. Yeah. The oxygen we don't worry about unless we're talking about oxygen toxicity, but we're not. But the nitrogen gets absorbed into our tissues as we're diving. Yeah. So the deeper we go, the more nitrogen we get. The longer we go, the more nitrogen we absorb. Okay. And as we're going down, we're on-gassing. As we're diving, we're on-gassing because we're taking on nitrogen. And then at the end of the dive, we start our ascent. The ambient pressure decreases, and that nitrogen is released, or some of that nitrogen is released. Yeah. So to get the nitrogen out, we have to ascend. And this on-take of this nitrogen absorption and release is what we need to manage. Does that sound familiar to everyone from ocean diver lessons? Yeah. So my question for everyone is, how do we manage that? How do we manage nitrogen absorption and release? We've got a couple of ways we can do it. Well, we as divers How do we
It's
know?
like deco stops.
Yeah, safety stops.
Yeah. So I would say we use BSAC 88 tables for our dive planning. Yeah. Or we used a dive computer for our dive planning. There are tools that allow us to manage the amount of nitrogen that we take on and that we don't take off, and that we absorb and we release. Yeah. And if we don't manage our nitrogen absorption and release, then we run the risk of DCI. Yeah. So that's where we're coming from, and we're talking about administering oxygen as our first aid measure for DCI or DCS or whatever we want, or the bends or whatever we want to call it. But we use the term DCI. Is that clear with everyone? Everyone happy there?
Yeah.
Yeah. Okay. Gareth, you got anything to add there, or?
No, that sounds good to me.
Perfect. Thank you. You all right, Bez? Yeah.
Yes, I just switched the microphone back on.
Oh, sorry, Bez. Yeah. I'll tell you what. I won't ask you again. If you've got something to pipe in, just do. Yeah.
Okay, yeah, carry on.
So,
Oh, there's something different about your microphone today.
is there?
I don't know. I hear you like from under the water.
Oh, okay. Let me just see what I can do. I'm using the same one. Just let me. I've got a couple of microphones. Is that any better?
Don't know because you're not speaking much.
Oh, sorry. Hold on. Is that any better?
Yeah, that's better. You're actually standing within a room now.
Okay. Oh, sorry about that. Yeah.
Yeah.
Yeah, but
okay.
you're clearer.
Perfect. Thanks for that. Okay, so let's get on to today's lesson. That was just a review of yesterday's and of how DCI, how to avoid the risks of DCI. Okay, so today is oxygen administration in practice. And what we're going to, the achievement targets for today are that we should be able to practically, we should understand how this works in practice. And the complementary role of fluid administration, how to arrange evacuation. I'm reading from a list if anyone can't tell. The immediate considerations in the case of missed decompression and where to get specialist advice, and why we don't administer Entinox, and why it's not appropriate for divers. Are you aware of that, Ruby?
Yeah, so as part of so we've got a little book called the JAL Calc, and literally in that for us giving Entinox, we actually have to ask, have you been diving the last 24 hours? So it is actually one of the things.
All right, perfect. We'll cover that. Then that's good to know. Well, yeah. Apparently we've got to tell you tactfully, which is easy for me, obviously. Yeah, and then any safety precautions. So let's carry on then. So again, this is just where we're fitting. Sorry, I couldn't get this slide to work properly, but we're sitting on DT6 here. Okay, this is in practice, but a theory lesson. We've also got a practical lesson to do that obviously we can't do at the moment. But yeah, that's where we're sitting at the moment. So the lesson outline. First, we're going to talk about the types of casualties that who we may administer oxygen to. Okay. Then we're going to talk about the practical aspects, and then we're going to finish by talking about some safety bits and pieces. Okay. So we're going to talk about the practicalities, and then actually doing the business, and any related considerations, anything we need to think about, the safety precautions, and our limitations as divers. That this is very much a first aid. We use oxygen as our first aid against DCI in a diving environment only, in a diving context. We're not out giving oxygen, we're not administering oxygen to the general public. Okay, but we'll talk about that fully later on. Okay, so let's talk about casualties first off. So BSAC records all incidents that take place in the UK. This is called the incident report. It's published every year. And they analyse the incident reports, and they base our training. They make training changes based on the recommendations from the incident report. So like all kind of first aid kind of things, this stuff changes over time, but it's guided from this incident report. So we take an assessment of everything that's gone wrong and work out, well, actually, this needs to be added to training to counter that, or this needs to be removed from training because that just doesn't work. So yeah, but what this analysis shows us is that the majority of our casualties will be breathing, which is good news. Okay, the majority of them will be conscious, and they'll be suffering from decompression illness. Okay, so this is what from the analysis of the incident reports over years, this is what BSAC have come back with as the most likely person that you're going to administer oxygen to. Okay. The first big good news is that they're breathing and conscious, right? Not so good that they're suffering from decompression illness. Now,
Problem with the conscious ones is they moan.
Yeah, well, they're divers, Gareth. It's part of their makeup, you know. They moan whether they've got this or not. So, but again, I've got a question for you. Based on yesterday's lesson, we've got our O2 kit assembled. What's the most appropriate way of administering oxygen to one of these conscious breathing casualties suffering from decompression illness?
The demand valve.
Through the demand valve, exactly. Using the face mask, okay? Because that gives us the highest concentration of oxygen. In fact, let's see what my mate BSAC says. That gives us the highest concentration of oxygen. Yeah. Exactly that. Now, the evidence says that casualties needing basic life support is actually much lower, okay? And I think it's around, there was a number in the text, but I removed it because I couldn't make any sense of it. 8 to 10 was what they said. So, and I couldn't make out what that number actually meant. So, but the good news is that the majority of people that have incidents are breathing conscious, and we can do something with that. We can give them our first aid treatment by administering O2. Okay, any questions? Magic, let's move on. So there are only 16 slides in this, so it'll be around about the same time as yesterday. Okay, so posture. What position are we going to put one of our casualties in who's breathing conscious and suffering from suspected decompression illness?
Hanging from their feet.
So we're going to lay them flat on their back, okay, while we administer oxygen. Okay, just as an aside, do we all know the signs and symptoms of decompression illness? Anyone get?
Sorry, I didn't hear that.
Oh, sorry. Do we all know the signs and symptoms of decompression illness? I've got a list in front of me, so I'm all right.
Nausea.
Well,
Joint pain.
Aches and pains in your
Itching, rashes.
Itching, skin
honest,
rash.
reading through the list, it makes you wonder why you'd ever want to go diving. But let's go through it. So we've got minor itches and rashes, numbness, tingling and joint pains, dizziness, nausea, headache and confusion, weakness, paralysis, loss of bladder and bowel control. Luckily, they're wearing dry suits, so that's good.
That's an age thing.
Sounds like a nerve gas.
We've got shortness of breath, shock and unconsciousness. Okay, so just the reason I'm listing these is that we normally cover these in DT2, I think it is, and I'm aware that some of us haven't covered it. So there's an awful lot of symptoms, and it does make you wonder why we want to do this at all, but that's why we manage this, isn't it? That's why we're using our tables, that's why we dive plan to avoid this. Okay, so we're all happy there. So if there's no suspicion of DCI, so if decompression illness or burst lung is not involved, legs may be raised to counter the shock. Okay, so that's bringing blood back to the core, I think. Is that right?
Yeah, I just love the word shock.
That's what, sorry?
The word shock is just, it always makes me laugh every
Is it
time.
very old?
or vague.
It's very vague, yeah. So normally, like when we laugh at people, he's like, we've gone to like jobs and they're like a bit shaken up, like, oh, they're shocked, like on the telly, and it's very different to what we class as shock.
Ah. Okay. So one thing we have to monitor for there, though, is if this affects breathing. So we're still monitoring our casualty, aren't we? And if this looks like it's going to be, if it's giving any problem to breathing, then we're going to lay them flat again. Okay. So we're all right with posture. Now, the quicker we get someone moving on oxygen, the better its benefit. Okay. There are two reasons for this. Let's see what BSAC's saying, see if you can make anything out of that statement. I took about 20 minutes trying to read that to work out what I thought it meant. And I would say that if casualty's now breathing 100% oxygen, or nearly 100%, based on his demand valve and face mask, The oxygen in the breathing gas is now at a higher pressure than the nitrogen that's in his tissues. All right. So we've got a gradient there, and that forces the release of that nitrogen. So the pressure difference between what he's inspired, what he's breathed in through our oxygen administration, is then forcing nitrogen release. Now, you got anything to say about that, Gareth? Is that how you read it?
Yeah, I mean, basically, if you've got, say, 50% of something in the solution already, and then you're trying to get the extra, you know, if you've got something that's then super saturated, you've only got, you know, like 50% you could add to it. Whereas if you've got 100% oxygen and 0% nitrogen in the bloodstream, it's much easier for the nitrogen in the tissues to pass back into the blood because there's no nitrogen already there. It's a sort of balance to it.
Yeah, perfect. So the second reason is that we can start to reduce any tissue hypoxia. Tissue hypoxia is when we've got reduced oxygen levels in the tissues. So giving 100% oxygen will improve that. Yeah. I mean, rather than get caught up on the technicalities, the thing that we should be taking away from this is that we start oxygen administration at the earliest point. As soon as we can, we get the oxygen on. So yes. We've also got to not ration oxygen. So we said we've got about 2.5 litres, 2.6 litres. The benefit of the oxygen, of being on oxygen, outweighs trying to ration it. So we use it until it's gone. Okay, and we get on it early and use it till it's all gone. And we're going to look later on about what we do once it is all gone. Okay, this will make you laugh, Ruby. So we've also got to attend to our casualties' mental state.
Not me.
Okay, so bedside manner, really, isn't it? And obviously, if someone thinks that they might be ill, thinks they might be taking a trip to the chamber, and is in a bad way, once we've cracked the oxygen out, we'll talk about it later on, but we're going to get medical professionals involved, aren't we? So they might be scared, they might be nervous. So we need to be, again, as divers, I'm not sure we are reassuring. I think it might take a different form, but we need to think about them as well.
You sound like a swan, basically. Yeah, like a swan.
Okay. And where we've got a second casualty involved, we need to use that second demand valve, so the constant flow. We're saying that we've got another casualty, another diver, whether they're showing symptoms or not, they've done the same set of dives as our casualty, so we're going to get them on oxygen too. Yeah. Yeah, and we've got to accept that that's going to go through our oxygen quicker, but really we're going to be calling people out anyway at this stage, aren't we? So if we don't have the oronasal face mask, we can use our normal fold-up pocket mask. Yeah, and we've got to accept that. Okay, now we've got to be prepared that the casualty's symptoms are going to get worse before they get better. Okay, there's two reasons for this. See, let's put these back up at the same time. We've got the initial reaction of the brain to the increased oxygen, and the fact that the passage of oxygen into the nitrogen bubbles in the blood, only a small amount is going to pass. A small amount is going to pass across, and that's going to increase the size of these bubbles. So it's going to increase the size of the nitrogen bubbles, but that's going to be offset by the reduction of the volume of bubbles. So the actual removal of the bubbles, there may be an increase in size, but the fact that we're on 100% oxygen means that they're going to be what's the word I'm looking for? Diffused or removed at a quicker rate. Does that make sense?
Mm-hmm. Yep.
So we're going to see them get worse before they get better. Now, oxygen toxicity. We all understand oxygen toxicity to a point, that increased partial pressures of oxygen, especially in a diving environment, will or can be toxic. Now, let's think about where we're going to be administering the oxygen. On the surface, right? And the ambient pressure on the surface?
1 bar.
1 bar. So the maximum the oxygen that we're delivering to them, 1 bar, even if we're giving them 100%. So it's not going to be a problem in that so the increased partial pressure is not going to be a problem in the short term. Okay, and the time scale that we're talking about increased partial pressure and central nervous system oxygen toxicity. That's not going to be an issue because of the time scales that we're talking about. Okay, and what about casualties who have suffered oxygen toxicity while diving? Let's say we've got a nitrox diver who's exceeded his maximum operating depth and is showing signs of in-water oxygen toxicity. So everyone know the signs and symptoms of in-water?
Seizures.
Convulsions.
Seizures, fatigue.
Yeah,
Possibly.
fittings, yeah.
Unconsciousness.
Yeah, and we would wait for any fitting to stop before lifting them to the surface. And then once they're on the surface, we administer oxygen. So once the signs and symptoms have disappeared, okay? So really, that makes it very simple for us. We've got no big problem with oxygen because if it's DCI, we give O2. If it's oxygen toxicity, once they've stopped any symptoms, we give them O2. We've really got one thing in our first aid kit for this kind of thing. That makes sense? Yeah, great. So no painkillers. So the reason for this is that painkillers confuse the symptoms. If someone's got a headache and we give them some paracetamol and that headache goes away, they don't have any symptoms anymore. And confusions of the symptoms makes it difficult for medical professionals to treat properly. So it makes diagnosis more difficult. So we don't administer painkillers. Clear so far? Brilliant. Okay, administering fluids. So I think we all know that dehydration is a predisposing factor to decompression illness. Okay, so and this isn't just in hot climates. If I think about us going for wheeze in our dry suits or on a small boat, that's a massive pain in the backside. So there's a tendency not to drink as much so that you don't have to take your dry suit off and go. So this is as big a problem in the UK as it is in the Maldives or somewhere lovely and warm and nice. So we should all, I think we've mentioned that at Ocean Diver, that we should all be hydrated for diving. And we can counter dehydration with fluids, but not all fluids. What would you say are suitable fluids for countering dehydration?
Water.
Yeah.
Isotonic drinks, you say, yeah.
Yeah. So still isotonic drinks, or water or squash. Okay.
Anything non-fizzy.
Yeah. Anything. Well, more caffeinated, isn't it? It's more that the caffeinated stuff is in terms of dehydration.
Yeah, not tea or coffee because that's
That's
diuretic.
a diuretic.
Yeah, tea, coffee, fizzy drinks, they're all out. Or yeah, and fizzy drinks. Yeah, you're absolutely right, Des. And we do that at the rate of around 1 litre per hour. So not huge amounts, but just small amounts. Okay. Now we can't allow the administration of fluids to interfere or delay with our O2 admin or with our evacuation. Okay, so basically the oxygen is more important than getting fluids down. Okay, and in the background we need to be, once we've cracked out the oxygen, we need to be talking to someone about either evacuation or giving some advice at the very least. So yeah, fluids are important, but not more important than evacuation or oxygen. So when do we not administer fluids?
Unconscious.
Yeah.
If we think they're going to go into have an operation or something like that.
Yes, if we think that they're going to need a general anaesthetic. There's also if we think they're going to vomit. So the result of vomit would make them more dehydrated. So if they're likely to vomit, so that would make matters worse. If they're likely to inhale the fluid, I'm not sure how we do that, but yeah.
I think that's Ruby's unconscious.
Right.
Yeah,
yeah.
reduced, yeah.
Yeah. So we're not going to pour fluids down someone who's just laid there, are we? That's weird on every level. And if we need a general anaesthetic, as John said, so if we've got something where we've got a physical injury as well as the DCI, So broken leg, broken arm, I dread to think, but yeah. So if we're in a situation where oxygen isn't available, fluids alone are beneficial in the treatment of DCI. Everyone happy with that?
Yep.
Great. So evacuation. Don't delay a call to the emergency services. Now we've got several ways that we can call the emergency service. At sea, generally, again, stop me if I'm speaking out of turn, we would use our boat skipper to do this because we're not piloting our own boat. We're not managing the radio. So as soon as we've got an incident, our dive manager, whoever's in charge on the boat that day, will be talking to the skipper and he would do this for us. But we've got several ways of doing it. So VHF channel 16. If we're on land, we'd call the British Hyperbaric Association or the Royal Navy Helpline, and I've got a number for that. But this information would be part of the information compiled by the dive manager ahead of the dive. So we'd have a pack here, and we'd talk to these guys. On land, we could call the ambulance, police, or Coast Guard. So, yeah, there's a whole list of ways we can contact emergency services. But let's say we've got our casualty. I've given the answers up here already, but we've got our casualty and he shows some sign of improvement. Do you think I'm qualified to make that decision? To say, actually, he's all right, take him off oxygen, he can go home now, have a cup of tea, mate. Well, I can tell you I'm definitely not, and nor are, maybe Ruby, but nor are any of us really. So irrespective of any improvement, we're still going to get medical attention, okay? And if that means a call to the British Hyperbaric Association and we talk to them and they say, well, actually, it doesn't sound, what's he done, what's happened, and then we take their advice. But it doesn't matter if we've got a sign of improvement, we still need to get the medical professionals involved. We also need to remember the casualties buddy in all this. And if we're evacuating the diver with a problem, we're normally going to evacuate the buddy at the same time and they'll go with them. In terms of helicopter lifts and that kind of thing, that might not be possible, but everything's on its own situation there, isn't it? And all relevant information must accompany any casualty. So what information do you think we're talking about there?
The computers.
Computer.
Yeah. Log sheets.
Live log.
Dive log sheets. The time they entered, from the dive log sheets, the time they entered the water, the time they came out.
If you look in the instant packs with your treatment sheet, so that should all go on there. You know, when you put them on O2, what the symptoms were, what their symptoms were when you checked it later, and what that time was, and all that sort of stuff, including names, next of kins, dive details, dive history, etc.
Now, a lot of years ago, I met on a boat. I met a guy who was a technician at one of the hyperbaric chambers, and he said they're not really interested in that. What he said is they treat symptoms; they don't treat theoretical things. They look at what's in front of them and they deal with that rather than anything else. But I don't think it can do any harm to give this information. So, yeah, that's what I think we should pass that information on. Yeah.
We like a lot of information.
Yeah, this guy.
If you call ambits, we want everything.
Yeah, it's funny. I've always thought that, and this guy said, "Nah, I'm not. We don't even look at computers. There's so many different types. We can't download profiles, and we don't deal with that. We just look at how bad they are, and then we take it from there."
I think the problem with computers is exactly what you said. You know, they don't know how to operate them all. I mean, let's be honest. You know, you switch from computer to computer. If it's not yours, you spend a couple of hours just swearing at it.
Yeah.
But if it's written down, I think that makes a huge difference. And I know when we sent Andy Garvey to the chamber in Aberdeen, they did say having all the stuff written down when his symptoms started and what we'd done to him or how we'd treated him, apart from taking the piss out of him, was most helpful.
All right, good. Okay, that's good to know then, isn't it? Okay, so remember we've got a fairly small supply of oxygen on the boat, or have we? Because we've got our O2 kit, and then we said yesterday we've got the boat's O2 kit. Now, when we also mentioned that we've got adapters to fit different cylinders for our O2 kits, didn't we? So we've got something that will connect to a J cylinder. We've also got something that will connect it to a scuba cylinder. But let's say we've run out of our O2 and the boat's O2. What are our options? Well, if we look, all of us did Gareth's talk the other week. Listen to Gareth's talk. Gareth's rebreather's got a small cylinder oxygen on there too. What's that, a 2 litre, Gareth? 3. So Gareth's got a 3 litre cylinder. It's unlikely going to be full, but there's a supply of oxygen there. We've also got, I think I mentioned it yesterday, some boats will blend nitrox on the boat, so they'll have J cylinders of oxygen. So we start with a closed circuit rebreather, and just through the unit itself, we can set that to deliver 100% oxygen. But then we go back to our same problem that we had yesterday. Could our poorly diver, could he manage that mouthpiece in his mouth? Maybe not. Is it the most effective way, or is someone going to hold his nose so that all he's getting is 100% oxygen? It's not going to be as good as our O2 kit. So in Gareth's case, we could whip his cylinder off and put it onto our O2 kit, couldn't we? And give it through an oronasal mask. Said it perfectly. So working down the line, we'd exhaust any O2 that was on the boat, whoever's that belonged to. Then we'd go and use nitrox. Now, again, we could use that from a rebreather or a semi-closed circuit rebreather. We'd have to get the operator of that rebreather to do the setting up of it. I wouldn't have a clue how to do it. But then we'd also go looking for rich mixes of nitrox, and we'd start with our richest first. So if sometimes people dive with, say, an 80% of nitrox, that's going to be more beneficial than breathing normal air. So again, we could use our special adapters and connect them to our diving cylinders. Yeah, using the mouthpiece, is it going to work? If it's not, let's do something different. It's not as effective as oxygen, but it's better than nothing. It's better than just breathing air. So that's the situation we're in here. But by this point, by the time we've exhausted this, then we're going to have called the emergency services, aren't we? Okay. So common considerations, mouthpiece might not be tolerated. This is what we talked about. And we don't get the concentration, do we? The best concentration we can get is through our demand valve with our face mask. And so this is all a compromise, but it's better than nothing. Yeah. Any questions on that one? No. So missed decompression stops. Let me put up what SISAC say and let you read that yourselves. So what we're saying there is that if someone misses decompression stops, and this is a difference between safety stops and the safety stop that we carry out at the end of the dive, or the safety stop that your computer gives you at the end of the dive, and a mandatory decompression stop. This is when someone has, if we go back to what we were talking about at the start, they are saturated with, well, not fully saturated, but they've got excess nitrogen in their body, and they need to release that by stopping at a certain depth to release that. Let's say one of them's had a problem and has missed that stop. Now there's no black and white answer here, and we've got to make a judgment that is kind of beyond the knowledge of a recreational diver. Okay, so what we've got to say is we don't wait for the signs and symptoms to appear. We get them on oxygen, we lay them down, get them quiet, and we administer oxygen as early as we can. Oxygen and fluids, of course, we've talked about administering fluids, and then we seek specialist advice. So what I'm saying here is that this may not result in an evacuation, but you and I as recreational divers are not qualified to make that decision. So this is where we seek help from the British Hyperbaric Association or the Royal Navy Diver Helplines. Yeah. So, and if they think it's safe, I think we all know that the decompression, it's not an exact science. Some days you'll be fine, some days you won't. So we're not qualified to make that decision. As soon as we crack open that oxygen, we're going to get medical professionals involved, okay? And even if that is just a phone call. And again, we're going to have those relevant information to hand to give to people. Does that make sense? The mist decompression. Yeah. You agree there, Gareth?
Yeah.
You ever been in a situation where someone's missed deco or has presented symptoms and we've administered O2, and I'm not trying to put you on the spot, but we've administered O2 and then not done anything beyond that?
No, I think we've always either phoned someone or just had them evacuated.
Yeah.
We've had a few little helicopter lifts over the years.
Yeah, no, that's exactly what I thought you'd say. I wasn't trying to catch you out or put you on the spot. It's just that's what we do, isn't it? Everyone, so that, again, this is a clear takeaway. This is something that you need to remember. So let's keep that in your memory. Entonox. So does anyone know what Entonox is?
Nitrous oxide.
Yeah.
With oxygen.
With oxygen, yeah. So yeah, is this what we call laughing gas then?
Yeah, laughing gas.
Is it what we call gas and air that we give to pregnant
Yeah, gas and air.
Yeah.
Perfect. Okay. So we don't administer it to divers. It's very soluble in the blood. You can see from the cylinder there, there are several ways of marking it. So it's generally blue and white, and it can be blue and white. There's 2 distinct bands on the shoulder, or 3 distinct bands around the shoulder, or blue and white quarters. So if I can't imagine a situation where we as divers would ever need to identify the cylinder of Entonox. But it's good to know that you have to ask that if anyone's been scuba diving in the last 24 hours. Just because, let's say, we go down the pub later on, I fall and twist my ankle, as I'm bound to do sooner or later, and I need some medical assistance, and I'm guessing Entonox is one of the first things you crack out as pain relief, is that?
Yeah. So we've got like a management scale, and Entonox is one of the earliest ones.
Yeah. Okay, so it is quite serious in that nitrous oxide is far more soluble in blood than oxygen, and it introduces significant amounts. It allows significant amounts of nitrous oxide to pass into the nitrogen bubbles, causing them to grow. So this will make our casualties condition worse. I've just said that, haven't I? Causes the bubbles to increase, and we should never administer. And even as just what we talked about, a non-diving incident following a dive. Now, ensure that but it sounds like emergency personnel are fully trained on this anyway, to a better level than we are.
Just why remember to ask the question.
Yes, yeah. So it's something to bear in mind, isn't it, for all of us? Okay, and to do this tactfully, I've got no idea how to advise you on that. Okay, safety considerations. So let's talk about our normal respiration. We normally breathe in 21% oxygen, and we breathe out 17% and a little bit of carbon dioxide. And the rest is still nitrogen that's gone untouched, yeah? That a fair statement? Let's say someone breathing 100% oxygen. What's he going to be exhaling? He's going to be exhaling
97%.
Exactly that. A very high concentration of oxygen with a little bit of carbon dioxide mixed in there, just for good measure. So with that, we need to be aware of enclosed spaces. And we've said before, we need to avoid sources of combustion. Oxygen on its own isn't combustible, but it does support combustion very, very well. And these need not be the obvious things you think about smoking. And the slides mention gas stoves, which is good. But we need to be in a well-ventilated area, away from things like electrical sparks, engine rooms, that kind of thing. I'm thinking about on a boat. Putting the kettle on while we've got him in the wheelhouse while he's on O2 is not a brilliant idea, is it? Okay, everyone happy there? We're coming up towards the end, so we're nearly done. So let's just say our limitations. Now, there are some people with certain chronic conditions that oxygen can make those conditions worse. Chronic lung disease, that kind of thing. Now, the likelihood that we're going to have these people diving is very unlikely. They're going to tick a box that says yes on their self-certification form, aren't they? So we shouldn't expect to see these people diving, all right? So we can only administer oxygen. We as divers can only administer oxygen in for a diving related problem. Okay, we're not there to serve the general public. We're just not qualified, are we? And we need to remember that oxygen's our first aid treatment. It's our first aid treatment against DCI. Okay, so we do have some treatment there. And that irrespective of whether there's an improvement, we're going to evacuate to a recompression facility, or we're going to take medical advice, aren't we? It's worth mentioning as well that in a hospital, a nurse needs a doctor's order to administer oxygen, don't they? They don't just do it off their own back. So we're not as qualified as a nurse. We're certainly not as qualified as a doctor. So this is purely limiting us to a diving problem. Yeah, everyone happy? So in summary then, we've talked about casualties. Does anyone remember the types of casualties we're likely to be administering oxygen to? What state? There was 3 things we said they would be there are 3 things we said about them.
Mainly breathing.
Breathing,
conscious,
and the Holy Trinity, suffering from DCI. Okay, so they're the type of people we're going to be dealing with. We're going to look at the posture. What position would we have them in for treatment, for administering oxygen?
Laying down.
Laid flat.
Laying flat. Yeah. If we didn't think that there was any DCI problem, we could raise legs to avoid shock, to help with the shock. And early administration of oxygen is positive. The sooner the better. Okay. We don't need to wait for that. We've got it there. We've got our O2 kit ready to go because we talked about that yesterday, didn't we? The dive managers made sure that's put together, ready to roll if everyone's got a problem. We've got fluid administration, but we're not going to let fluid administration get in the way. It's beneficial, but we're not going to let it get in the way of administering oxygen or in the way of evacuation. And in the case of missed decompression stops, we're always going to administer oxygen, whether we've got symptoms or not. We're always going to seek medical advice. And Entonox, we're just not going to use it, or we understand now that the problems with using it and the safety precautions that we need to use with the diver's exhaled gas when using 100% oxygen. And we're only using oxygen for diver related problems. Any questions?
Oh, very good, thank you.
Not good. Okay, I'll
I take it the sort of symptoms of diver-related injuries, DT2, we're going to run that again shortly.
Yes. Yep. That sounded like a volunteer there, Gareth.
Well, I suppose so.
Oh,
That's a begrudging.
that's like everyone took one step back there, wasn't it?
Yeah. I was just going to pick up on one thing.
Yeah.
When we were talking about oxygen toxicity, I don't know whether it gave the impression we were treating oxygen toxicity. We're not. We're basically saying if the diver has suffered oxygen toxicity, which may have resulted in the diver relating injury, i.e. he ox-toxed and then missed his stops, so he's got DCI, we can ignore issues of ox-tox in preference for giving them oxygen and treating them. And if they start fitting, you just stop giving them oxygen till they stop fitting, and then you give them oxygen again. And if they start fitting, you stop again.
Yeah,
So it's quite simple.
I think if we start that at the beginning, we shouldn't be bringing anyone up. We need to stop.
Yeah, but I think that statement on the slide about the ox-tox is someone having had oxygen toxicity, it does not preclude you giving them oxygen, rather than that's something we're treating. If that makes sense.
My understanding, Gareth, is that as soon as they've reached normal air, that their convulsions should cease and their toxicity should reduce considerably.
Yes, I mean, that is the point. But I think the main point is that in the early days of nitrox coming on board and rebreathers later, is there was a concern if someone's overdosed on oxygen, why are you giving them more oxygen? And I think the point of the O2 course is to reiterate, don't care about that. If they've got symptoms, you give them oxygen. If they happen to fit again, which they shouldn't really, you just take them off the oxygen until they stop fitting, and then you put them back on as soon as they are back to normal.
Yeah,
Question that could be posed as well. Is there any situation where you would not, or where we would not give oxygen?
I don't think there is. No.
No, not in the case of a diver-related issue.
No, that's it. That's the whole point. Oxygen is going to be
I think
beneficial,
DT
whichever.
also emphasises that, because that runs through all the likely things you're likely to have a diver suffer and what the treatment is, and basically it always comes out the bottom at the same one. Give them oxygen.
Yeah.
Exactly. Yeah, that was really why I was asking the question.
Yeah. No, thanks, guys, that's it. It's there's no reason not to give oxygen, is there?
No. I mean, the other thing, I think we touched on it, is that the recommendation is that we do have an incident log, and we do write down details about what examinations we gave them, what the symptoms were, when we gave them oxygen, how much fluid we gave them, when we ran out of oxygen.
See my video?
Yeah, that's covered in DT4.
Okay.
And we haven't done that because to do that properly, we need to be sat in front of someone doing you need to be up close to be, or in my view, I don't see we can do that effectively without being up close and without doing the pushing and pulling and the observations and that kind of thing.
Yeah, I just thought I'd add that as sort of a comment when we're giving oxygen. That's all part and parcel of the process.
The point though, on the incident report form, I don't know if you can see the video, but the emergency details there are always on the form. Anyway, so
Yeah.
that's okay.
A couple of other things I also thought of is, we were talking about using the rebreather for giving oxygen.
Yeah.
Because we do have adapters in the set that will allow you to use a diving cylinder and put the oral nasal mask proper O2 kit onto it, I would say that would be the preference over using the rebreather, because it goes back to that business about, it's a nicer thing to breathe off a proper O2 oral nasal mask than off a rebreather.
Yeah, I mean, in that situation, I think we pull the 3 litre off your rebreather, and
the same really for decompression cylinders, and nitrox diving cylinders, etc., etc. And you did also mention what happens if we don't have an O2 set or any O2 equipment. And again, if there is a diving cylinder full of nitrox, pick that up and use it. If you don't have an O2 set, or if the O2 set won't work, or if someone's fiddling to get the O2 set working. If the casualty can actually comfortably use a demand valve, something is better than nothing.
Yeah. Yeah, absolutely.
And I got one little technical point on interstage pressures, if you're interested.
Oh yeah, why not?
Well, there is an inference that the pressure that you draw off off the second stage is at ambient pressure, and it isn't. That's why it goes hiss when you push the purge valve in.
Yeah.
Most regulators are set, and it's manufacturer specific, but they're set so the interstage pressure, i.e. the pressure between the first stage and the demand valve, is always at approximately 10-ish bar. And the point about a diving first stage is that when you go to 10 meters, it's still going to be 10 bar in that hose, even though the ambient pressure's gone up a bar, because it will automatically increase. So, absolute, it would be 11 bar, but relative to the depth you're at, it's still at 10 bar, if that makes sense.
Yeah, I was trying to give a simple, bearing in mind we've got ocean divers and you know what I mean?
Yes, yeah.
So yeah.
Look at Charlie.
That's the highlight of the evening, isn't it?
You try to laugh to it, just cat's having a dream in the corner. It's like, tickles through.
Okay, well, I'm going to stop the recording now then. Everyone happy?
Yeah.
Yeah.